Hello everyone, my name is Dipika Gopal. I'm a cardiology fellow at the University of Pennsylvania, and I'm excited to talk to you about my project entitled Focused Cardiac Ultrasound Curriculum for Internal Medicine Residents. I have no disclosures. To put my research into perspective, it is useful to go over some general background on point-of-care ultrasound, and more specifically, focused cardiac ultrasound. In the last decade, point-of-care ultrasound, or POCUS, has been one of the most rapidly growing fields in medicine. It is used in various clinical settings, including the emergency department and the intensive care unit, and performed by multiple different medical and surgical specialties. Within the field of POCUS, focused cardiac ultrasound, or FCU, has grown tremendously with the miniaturization of machines and the ease of acquiring images. An FCU is a very efficient means of obtaining critical information about a patient that can influence time-sensitive decisions, as it is performed by the primary team in real time using portable bedside machines. Following suit, several medical schools have started to incorporate cardiac ultrasound medicine into their curricula. FCU has a high level of diagnostic accuracy when done appropriately. One study demonstrated a sensitivity and specificity of 94% for detecting an ejection fraction of less than 40% in handheld cardiac ultrasound images performed by internal medicine residents. This has been shown in detection of pericardial effusions as well. Interestingly, inferior vena cava size and collapsibility can also be used to predict heart failure readmission rates better than demographics, comorbidities, vital signs, and even biomarkers, as shown in another study. Due to this, there is a huge push in residency training programs to adopt FCU into clinical practice and to train residents to become proficient in FCU. As shown by curricula published thus far, it is a very teachable skill. However, based on a survey in 2013 of all U.S. program directors, FCU is performed less than 15% of the time in real clinical practice, yet at the same survey responders stated that their programs regard it as a priority to learn. So herein lies the gap. There is no standard curriculum to teach FCU to residents, and no standard assessment process. Therefore, our objective was to develop a sustainable focused cardiac ultrasound curriculum and create a means to assess the effectiveness of such a curriculum, with the goal that others might be able to adopt the curriculum and/or the assessment survey in their program. The primary outcome of the study was a change in mean confidence and knowledge from the pre- to post-curriculum assessment. Our methods were as follows. The curriculum was embedded into the existing clinical cardiology education block for residents rotating in the cardiac care unit and cardiac intermediate care unit. There were 8 residents that rotated on those services every 2 weeks, and each 2-week block we emailed out the pre- and post-curriculum assessment survey at the beginning and end of each block, respectively. The curriculum was administered or withheld on alternating 2-week blocks in order to generate 2 cohorts of residents, those who received the curriculum and those who did not receive the curriculum. The curriculum was comprised of a 30-minute didactic portion and a 60-minute hands-on practice portion. The didactic portion of the curriculum was a 30-minute PowerPoint presentation on how to acquire images and identify key cardiac structures. Residents were also exposed to high-yield diagnoses, including right and left ventricular dysfunction and tamponade. The hands-on portion was a 60-minute session led by a cardiology fellow or attending physician where residents would practice scanning and interpreting the images as a group with feedback from the preceptor. The assessment survey consisted of 8 questions assessing confidence and 16 questions assessing fund of knowledge. Each of these sections included questions in 3 main learning domains, including acquisition, interpretation, and integration. The QR code on the right side of the screen and on the next 3 slides can be used to see the survey in its entirety. I will share with you a few sample questions in each of the 3 domains. In the acquisition domain, we asked learners what their confidence was in optimizing image quality using knob manipulation and tested their knowledge of probe manipulation to obtain a desired result in the image. With regards to interpretation, we tested their confidence and knowledge base in identifying basic cardiac anatomy using the image displayed, where the right ventricle was labeled A, left ventricle B, right atrium C, and left atrium D. Lastly, to evaluate clinical integration, we showed this video of acute right ventricular dysfunction with a clot in transit and asked how confident they were in arriving at a diagnosis and their knowledge of what the diagnosis was. Our results reflect assessment survey responses over a 1-year period of time during which the curriculum was administered. Of 246 residents who were asked to take the pre- and post-curriculum assessment surveys, 79 residents completed the pre-curriculum survey and 50 completed the post-curriculum survey, with a response rate of 32%. Of the 50 that completed the post-survey, 34 stated that they received the curriculum and 16 stated they did not. There was an equal distribution of postgraduate year level, and most of the residents had never received a curriculum like this before. Among the 50 residents that completed the post-survey, the mean change in confidence score on a scale of 1 to 5, 1 being least confident and 5 being most confident, was 0.99 in the group that received the curriculum compared to 0.39 in those that did not. The mean change in knowledge score from pre to post curriculum was not significantly different in the two groups. 33 residents were identified as having taken both the pre and post curriculum surveys. Of these, 76% or 25 stated that they had received the curriculum. Among these 25, there was a 13% mean increase in knowledge score in the group that received the curriculum compared to 7% increase in the group that did not receive the curriculum. While confidence scores improved regardless of whether the resident had received the curriculum or not, there was a statistically significant greater increase in mean confidence score among residents who received the curriculum versus not. This is seen here on the first row, 1.2 increase versus 0.85. This is a graphical representation of the confidence score on each question. On the y-axis is the confidence score on a Likert scale of 1 to 5, 1 being least confident and 5 being most confident, and on the x-axis are the 8 questions. The blue bars represent the pre-survey confidence scores, and the green bars represent the post-survey confidence score in the group that did not receive the curriculum. Overlying that are the pink bars, which represent the post-survey confidence scores in the group that did receive the curriculum. For the confidence assessment, 2 questions in the acquisition domain, question 1 and 8, were identified as most able to discriminate whether the residents had received the curriculum. Highlighted by the red circle on question 1, you can see that the mean confidence score in optimization of image quality with knob manipulation, including gain and depth, decreased from 3.3 to 3.2 in those who did not receive the curriculum, and increased from 3.3 to 3.5 in those who did. Highlighted by the second red circle on question 8, you can see that residents who had the curriculum experienced a greater increase in confidence in correctly identifying cardiac anatomy compared to residents who did not receive the curriculum. Mean confidence increased from 3 to 3.5 in the group that did receive the curriculum and increased from 3 to 3.1 in the group that did not. We believe this data speaks to the benefit of an overlying FCU curriculum on top of general clinical cardiology teaching to specifically harness the skill of acquiring and optimizing images to interpret. In conclusion, our results demonstrate, first and foremost, that internal medicine residents at our institution, on average, have a high fund of knowledge in bedside cardiac ultrasound interpretation, albeit with some heterogeneity. It was also evident that after a short didactic and hands-on session, internal medicine residents felt substantially more comfortable in optimizing images with knob manipulation and identification of cardiac anatomy. We believe the hands-on portion of the curriculum was especially influential in harnessing these skills to be carried forward in clinical care. Lastly, the assessment survey provided a concise and reliable way to discriminate between those who did and did not receive the curriculum. A few limitations should be noted, including the small sample size of residents and the relatively low response rate on the pre- and post-curriculum assessment surveys. One factor that limited the assessment of the impact of our curriculum was self-reporting of receipt of the curriculum by the residents. Additionally, confidence scores are subjective and are an imperfect indicator of competence. Lastly, there was likely crossover between both groups, which may limit statistical comparison. Future studies will help us understand the endurance of the curriculum, retention of knowledge, and skill in image acquisition, and the effect it may have on clinical care and subsequent diagnostic testing. I would like to thank my mentors, Drs. Prenner, Baston, Adusmali, and Jagazia, for their help and guidance, as well as all other contributors to this project. And thank you again for your attention.